Our first speaker is Dr. Jay Sizemore, who is the chief of the Division of Infectious Disease for the UT College of Medicine, Chattanooga, which is part of our department.
Somebody needs to mute all those people talking in the background.
Gotcha.
Our second speaker will be Dr. Charles Woods, who is professor and chair of the Department of Pediatrics, also the chief medical executive for Children's Hospital at Erlanger. Both of our speakers are infectious disease physicians. And again, we really appreciate this update about COVID. Dr. Sizemore, if you'll go ahead. And please, everyone else, mute your audio. Thank you.
Good morning. Thank you, Pam, and appreciate everybody signing on this morning. Appreciate the opportunity to work with Dr. Woods on this COVID-19 update. I wanted to start by thanking all of you all, certainly those of you who have been here over the last year and a half and have helped with our effort at Erlanger in addressing the pandemic. I'm going to focus on 4 areas in my portion of the talk. I'm going to look at current epidemiology, treatment for adults, vaccines for adults, and current Erlanger protocols. And again, the Erlanger protocols may be somewhat redundant for those of you who have been here, but certainly for our new interns and residents, it might be helpful just to remind you of where we are with those, especially with the recent increase in number of cases.
24 hours.
So with all due respect, we got to have everybody muted. I mean, it's just, we've been doing this for a year and a half.
Spread the skin in the tubing.
So Kim, do we not have the power to mute everybody? All righty.
All right. I've got everybody muted. The ones that I can't mute are the ones that are on their phones. They're not muting. If they're on their phones, they need to mute their phones.
Okay.
Usually *6.
Okay, thank you, Kim. So the current determinants of the pandemic, at least in my mind, are listed on this slide. Last week, Rochelle Walensky, who's an infectious disease physician now heading the CDC, termed this portion of the pandemic as the pandemic of the unvaccinated. 99% of recent deaths have occurred in those that are unvaccinated. 97% of recent hospitalizations here in this country have been unvaccinated. It's been really regional, and we'll touch on this as we go through some of the US epidemiology, but certainly those areas with lower vaccination rates, which unfortunately are all around us and to some extent include us, have been hit harder. Many of you may have heard about the kind of most prominent recent outbreak in Southeast Missouri, where their hospital quickly filled up with COVID-19 patients in an area with very low vaccination rates. But cases, hospitalizations, and deaths are now unfortunately up. And as we were thinking about at Erlanger how to unwind from some of the policies we've put in place 18 months ago, we're now looking at how we rewind and deal with this uptick in cases that we're seeing. New data from the CDC yesterday have estimated that 83% of the cases seen in this country are now caused by the Delta variant. And certainly we feel like that's what's led to the increase in cases in our areas. And certainly as we've relaxed mitigation strategies and requirements, this will lead to increased transmission of the more infectious Delta variant, especially amongst those individuals who are unvaccinated, leading to the cases that we're seeing currently. I'm going to start with a global review of epidemiology and take that all the way down to what we're seeing at Erlanger. So this is the dashboard that you can access on the WHO website. A few takeaways, just the global map in the shades of blue are representative of case counts, and certainly in the US, Brazil, India, increasing outbreaks in Indonesia. These countries are represented in the darkest colors with greater than 5 million cases reported. I'll draw your attention to the lower left-hand side of the slide, where it's looking at new cases, confirmed cases, 190 million now, deaths over 4 million. Again, these are those that have been reported. And interestingly, yesterday eclipsed the 3.5 billion doses of vaccines that have been administered. And although that's recognizing that as an incredible feat, in my mind, we still have a long way to go with respect to vaccinations. This looks at some of the trends that have occurred over time by week and by WHO region of the world. I think the two things to take away from this slide are the general rise in both cases and deaths represented on the right-hand side of the slide, which represents the increase in cases and deaths that we're seeing because of the Delta variant. And the other thing that I've continued to point to throughout the pandemic has been the Western Pacific region, and in particular, countries like New Zealand and Australia. And you can really see in countries that were united and had a very aggressive and unified front towards controlling the pandemic, have really seen very little in the number of cases and or deaths. And certainly they're to be applauded for that. Here, a little different breakout. And again, you can view these reports on the weekly WHO epidemiology report that's released. You can see the new cases in the last 7 days by the WHO region, cumulative cases and cumulative deaths. And certainly, although we're lumped into the Americas, this table does not reflect at least what we're seeing on a national and certainly more local level. So let's turn to the US. These are CDC data, 33 million reported cases of COVID-19 since the pandemic started, over 600,000 deaths. Again, so it's unbelievable that we can still have people comment that this isn't a pandemic or this doesn't impact people's lives, but we continue to have to deal with some of that skepticism. But again, we're dealing with real people, lost lives. Certainly most of us by this point have known somebody who's succumbed to SARS-CoV-2. The kind of news of mediocrity, if you will, is the vaccine news. So 186 million individuals, US citizens who've received at least one dose of the vaccine. This represents 56.1% of the total population. If you look at it by age cohort, 68.3% above 18, 65.6% above 12, and 89.1% over age 65 have received at least one dose. Similar data is reported at the bottom of the slide for those who have been fully vaccinated. 48.6% of the total population. This number is slowly creeping up, but has flattened over recent days. And certainly this is the number I think that we ought to be pushing to change in order to suppress ongoing cases associated with the Delta variant. Again, just some graphs over time where you can see the various waves that have been reported. You've got number of cases reported on the y-axis on the left, time on the x-axis, and this is currently the slow increase that we're seeing because of the Delta variant. Again, certainly at least not now, the magnitude that we saw back in the late fall and early winter of 2020, 2021, but certainly concerning. Deaths that followed a similar pattern. Again, on this slide, deaths on the left x-axis, total vaccinations administered on the, on the y-axis on the right, deaths on the y-axis on the left, and time on the x-axis. So you can see a slow uptick in reported deaths related to COVID-19, and you can see the flattening of the curve with respect to administered vaccine and the very clear relationship between decline in US deaths as vaccinations ramped up. So where are we in Tennessee? Again, this is Tennessee Department of Health slide that can be easily accessed. This is the most recent update from July 19th, listing the total cases, confirmed cases, probable cases, recovered cases on the top, cases by county in the middle, and the daily count of cases for the last 120 days. And again, here in Tennessee, just like nationally, we're beginning to see the uptick in number of cases. If you look at Tennessee, about 38.5% are fully vaccinated. Remember that national number is somewhere around 49%. If you look at some of the best vaccinating states, you've got Vermont at the top at around 67%. And certainly they've been much less impacted by the Delta variant based on how well they've been vaccinated. And then if you look at the worst state, which happens to be Alabama right now, only 34% of their population has been fully vaccinated. And so you can see Tennessee is really not far behind or far ahead, if you will, of Alabama. And so I think much work to be done in our area. If you look a little closer and drill down to Hamilton County, the numbers are somewhat better than the overall state of Tennessee with 42% fully vaccinated. But what you can see on the graph at the bottom left-hand side of the slide is again the same uptick in new cases that we've seen elsewhere. And so if you say over the last 14 days, Hamilton County has averaged 36.1 new cases reported per day for the 14 days prior. And again, that was 6/21 to 7/4. That was 13.4. If you drill down to 7-day averages, we were at a rolling count, we were down to an average of 8 to 9 in late June, and now are up in the upper 40s. So a significant increase. And again, all this is felt to be largely driven by the Delta variant. So where are we at Erlanger? We had one case in-house 4 weeks ago. Yesterday, we had 20 cases of COVID-19. 6 of those were in the ICU. 60% were male. 50% were Hamilton County residents. 75% had a BMI over 25. 40% a BMI over 30. Apologize for the typo, but 70% were greater than 50 years of age. And although the documentation was not crystal clear, only one of the 20 were fully vaccinated. This was a gentleman in his 80s who had finished the vaccine series back in March. So again, I think with what we're, with that last statistic, we're really seeing what's being reported on a national level, at least in the hospitalized arena. This is a pandemic of the unvaccinated. Again, we're continuing to see deaths. We've had at least 4 deaths in the last 2 weeks directly related to COVID. 92-year-old male, 59-year-old female, 57-year-old female, and the 5-year-old that many of you may have heard about from over the weekend. So again, I think we need to continue to take this pandemic seriously and do our due diligence to address it here at a local level. So I'm going to shift gears from epidemiology and talk a little bit about therapeutics. Again, this is a relatively rapidly shifting target. And it turns out it's been a somewhat frustrating topic because of really the lack of effective treatments that have come down the pipeline. It's not incredibly surprising given what we know about the treatment of most other viral diseases, and more specifically coronaviruses. The ID Society, Infectious Diseases Society of America, and the NIH have developed living guidelines that have largely driven our treatment paradigms in these countries. Again, this may be review for many of you. I've chosen to highlight some of the drugs that are currently in those guidelines and are currently being used at hospitals all around the country: dexamethasone, remdesivir, baricitinib, tocilizumab, and then the monoclonal antibodies listed at the bottom for outpatients. And again, I'm going to touch on each of those just briefly, brief overview, not enough time to go in depth to a lot of the data behind the use of these medications. I've chosen to use an NIH chart just because it provides a brief, quick, nice summary of the drugs that are currently being used in hospitalized adults by severity of illness, and then the grade given the evidence behind the use of each of these drugs. So again, that's available from the NIH. Again, in our facility, fair amount of dexamethasone and remdesivir use with some use of the tocilizumab ongoing. Again, thanks to a lot of providers, probably some of whom are on this call, our pharmacy department, our critical care department, intensivists who've gone and reviewed all of this data and helped develop the protocols that our medical staff has supported in treating COVID-19 during the pandemic. So remdesivir, as many of you know, is a nucleoside analog. It inhibits RNA-dependent RNA polymerase. It's given FDA approval in October of 2020, indicated for those over 12 years old and weighing more than 40 kilograms. It's typically given 200 milligrams on day 1 and then 100 milligrams on days 2 through 5, with some leeway to extend to 10 days. This was initially provided to us free of charge. We're currently paying for it. More and more data have emerged with respect to its use. And frankly, we've narrowed our use as that data has become available and seems to benefit only a very relatively narrow sliver of individuals. Baricitinib is a JAK inhibitor. It's indicated for those under an EUA greater than 2 years of age. It's designed to be used in combination with remdesivir. Again, typically those people who are rapidly progressing with escalating oxygen requirements. It's a PO drug given for up to 14 days. And really the main adverse event associated with it has been venous thromboembolism. And so certainly steps are taken for those using this particular medication to prevent that AE. Tocilizumab, again, we've got a protocol at Erlanger behind using that particular therapeutic. It's a monoclonal antibody to IL-6 receptor. It's given, it's approved as under an EUA for use in those over 2 years of age with corticosteroids and those requiring oxygen. And again, the details can get a little more granular with respect to who's going to qualify for this particular medication. Certainly, if you're at high risk or have an ongoing infection, this therapeutic would be contraindicated, and it's not designed to be used with the JAK inhibitor discussed previously. Finally, I wanted to touch on the monoclonal antibodies. These are the therapeutics, really the only therapeutics that have been available in the outpatient setting. I think most agree that their benefits have been marginal, but their EUA was granted for high-risk individuals with mild to moderate COVID-19 disease who may be at risk to progressing to severe disease and or hospitalization. The monoclonal antibodies that have been given in EUA are listed on the left-hand side of the slide. The most recent product that we were using at Erlanger was the combination product with bamlanivimab. Because of resistance issues with the beta and gamma variants, the distribution of this combination of monoclonal antibodies has been stopped in this country. Our program at Erlanger is currently on pause as we expect to get the casirivimab product moving forward. Again, with all these therapeutics, it's been enlightening to watch this process go through and to see the rapid developments of these drugs. But in all honesty, compared to the vaccines, which I'll talk about next, the impact of these therapeutics has been underwhelming, in my opinion. So with vaccines, quickly we'll touch on the Pfizer, Moderna, and J&J products. First with the Pfizer, this is an mRNA technology looking at targeting response to spike protein. 2 doses given at 0 and 21 days intramuscularly. The EUA was originally granted on December the 11th. It's been expanded to those now 12 years and older. It's 95% effective. A real-world CDC study of healthcare workers revealed 90% effectiveness and 88% effective against Delta symptomatic infection, at least in unpublished data released from the company. So again, this is the vaccine that we has been our workhorse at Erlanger. Its main handicap early on were its high storage requirements and super cold freezers. Some of those storage requirements have been modified as we've moved forward through time, but Pfizer has certainly been our workhorse. Moderna, very similar to Pfizer, mRNA technology targeting the spike protein given at 0 and 28 days intramuscularly. Its EUA was granted a week later in December for those 18 years and older, and very similar protective effects to the Pfizer vaccine. And they also, the company also has unpublished data with respect to the Delta variant that looks very encouraging. Along with the benefits of these vaccines, which have been tremendous, the adverse events, as with any vaccine, has garnered a lot of attention. In specific with the mRNA vaccines that I've just discussed, myocarditis has been the most prominent AE. Most of these, again, we've given close to 200 million doses of these mRNA vaccines, or over 200 million doses. Most of the cases of myocarditis have occurred after the 2nd dose, and most in young men. And again, we're looking at about 300 cases that have met the CDC case definition. Although most require hospitalizations, most have recovered in short order. And the Advisory Committee on Immunization Practices completed a review of the myocarditis data last month and made no change in the current vaccine recommendations. J&J vaccine, it's a single dose. It has fewer storage requirements. It can be stored in a refrigerator. 18 years and older, it's an adenovirus vector technology, again, to deliver a message for spike protein production. Its EUA was granted in February of this year. There was a pause for thrombosis with thrombocytopenia and then a resumption. And then more recently, a rare Guillain-Barré syndrome was released earlier this month. The overall effectiveness data with the J&J vaccine has been less. There's been even more questions with respect to its ability to protect against the Delta variant. And the GBS data will be more thoroughly reviewed again by the ACIP tomorrow in their meeting, along with some other data that we'll discuss in just a second. So other hot topics with respect to vaccines everybody's always talking about boosters. Right now, there's no boosters recommended. The ACIP is going to look at boosters in their discussion tomorrow with respect to the immunocompromised population. This may impact 2 to 4% of the US population, and there may be recommendations with respect to boosters earlier in that population. Alternative strategies, I've listed a commentary from Nature earlier this month having to do with mix and matching different types of COVID vaccine. It looks like the mRNA vaccines are really good at generating antibody responses, whereas the vector vaccines may be more robust in generating T-cell responses. So there's certainly a lot of activity, mainly with the AstraZeneca product, which is not available in the US, and the Pfizer together, but we'll continue to look at this strategy moving forward to see if we can optimize responses and protect more of our population. Dr. Woods is going to touch on data as we look at vaccinating those under the age of 12. Touch briefly on the AstraZeneca vaccine. It's very similar to the J&J vaccine, and a central AE, as with the J&J, has been thrombosis with thrombocytopenia. Again, it's still being used widely in Europe. And then Novavax is a company here in America where studies are ongoing. It's an adjuvanted protein vaccine, as many of the vaccines that are currently available on our vaccine schedule, and it's a 2-dose series. So more info to follow on that. Just a brief comment about hesitancy and vaccine converts. There was an interesting commentary on in the New York Times morning report earlier this week, talking about those people who initially had vaccine hesitancy, and there were 3 kind of central themes identified as those for those individuals who went on to now want the vaccine after some initial hesitancy. And those 3 factors were a safety profile after 300+ million doses have been given. So again, there were some people who wanted to wait and see. And I think certainly historically, the most adverse events that have been associated with vaccines have occurred acutely. And so I think that's a reassuring message that we can pass along, that, yeah, there have been bumps in the road. There are AEs with this vaccine, but the risk benefit profile or ratio is still clearly beneficial for vaccination. Certainly you as providers providing pro-vaccine messages can be very powerful in influencing unvaccinated individuals or those on the fence to get a vaccine. And then finally, learning that not being vaccinated will prevent people from doing some things has caused other individuals to be vaccinated. So I just thought this was interesting as we looked earlier at some of our vaccination rates, but I think this is probably the true magic, at least in my mind, that's occurred throughout the pandemic, is the rapid development of effective, safe vaccines that we can use to save hundreds and thousands of lives. I'll finish up with just a brief review of Erlanger Policies and then turn it over to Dr. Woods, focusing on PPE, employee health screening, testing, and visitation. As a reminder, there's universal masking as part of our PPE policy. This can be an N95 or a surgical mask. If you're in a non-clinical area, a homemade mask is acceptable. If you're in the clinical area, we ask that you wear a surgical mask or N95. When you're in a patient's room, you need a hospital-issued mask and eye protection. Regular eyeglasses are not considered protection, so goggles, face shield, or anything that's issued by the hospital would be acceptable. And then for our COVID-19 patients, we have on the adult side contact, droplet, and airborne precautions, and you can see the requirements listed to enter in those rooms. Employee health screening. Again, we had relaxed this to some extent by reporting for duty when a test that he or she is free of symptoms that could be associated with COVID-19. Given the recent number of increased cases at our facility, we've decided to return to the attestation form that's available on the internet. That policy went into place yesterday, and that will basically allow our employee health some increased efficiency at managing these cases. As we saw our cases increase, we also saw the number of our associates who were symptomatic increase as well. Again, we think our number at Erlanger as far as vaccinated associates is somewhere in the 75% range. So certainly there are a fair number of our employees who are would still be exceptionally vulnerable to the Delta variant. As far as testing inpatients, our workhorse has been the Abbott ID Now. That's a rapid test that's available. If you're concerned about false positives and false negatives, there's two other technologies, the respiratory viral panel and the Panther PCR that we have available in-house. If you need a rapid turnaround, you're going to get your best bet from a respiratory viral panel. But the Panther PCR has typically resulted in 24 to 36 hours. Finally, visitation. There's one screened mass visitor per 24-hour period. If a non-COVID patient's in the ICU, that visitation period is from 4 to 8 p.m. If it's a for non-COVID patient, that visitor can stay overnight. Single visitor, no switching. There's certainly exceptions for children and pregnant women where 2 providers are allowed, and end of life where 4 family members are allowed in for non-COVID situations. These are obviously subject to change based on the activity that we're seeing in-house. There's no visitors for COVID-19 patients during the isolation period, except with end-of-life exceptions with a signed waiver, and those can all be managed as can other exceptions by the house supervisor. So in summary, the pandemic is not over. The Delta variant has certainly thrown us a curve. Please follow our protocols that I've just reviewed. The detailed policies and procedures are available on the intranet. Vaccination clearly provides the best protection. I would ask for your cooperation to be an ambassador to your colleagues, to your friends, to your family. And certainly this is a rapidly evolving topic with still much to be learned. So again, thank you for your attention today, and I'll turn it over to Dr. Woods.
Thank you, Jay. And I hope all of you realize how fortunate we've been with Dr. Sizemore's leadership and others to guide the system and all of us through the pandemic to date. And sadly, we're not quite done yet. If I can get this open here for you. Okay, just a quick hopefully you can see this now. And let me know if you're not seeing my screen.
We can see
Jay?
it. Good. Yep.
Okay. So just a quick overview of basic science, just so you know what we know about the virus in the lungs. It affects multiple cell types, including the pneumocytes and alveolar macrophages. But it also goes beyond. We know it also infects vascular endothelium and can involve both brain and systemic vascular involvement of endothelial cells and deeper into vessels. And that maybe explains part of the complications that have been seen. And we've seen this even in children in occasional cases, but certainly more severe in adults. And I want to remind you about transmission. We've talked for years about aerosol, airborne versus droplet, and then of course fomite or contact. And this virus probably has had all three, but certainly droplet being significant, but also aerosol in terms of small particles, especially with low airflow in rooms. And we now know that this dichotomy of droplet versus airborne is a bit false. And somewhat certainly depends on airflow factors. So in homes and other closed environments where there's not a lot of air exchange, relatively short periods of time with someone who is breathing out virus may result in a lot of infection risk, whereas being certainly in higher flow areas, certainly hopefully the hospital and even maybe large stores or other venues, those risks go down. And just to remind you of herd immunity, the more contagious a virus is, the more aerosol type spread there may be, the higher proportion of the population that has to be immune before you see circulation really drop. So we're still not quite sure about where this is. And with this new Delta variant, it actually might be a little higher than it used to be, since it's probably has a higher reproductive number than the other variants. But we're probably still looking at somewhere between 65 and maybe 80% of the population. But we're approaching that in pockets. I think we may have pockets of population where we've had 80% vaccination, and others, of course, where there's not. So there are places where this pandemic of the unvaccinated is really going to depend in part the magnitude of the density of those populations together. And just to remind you, I'm not going to spend a lot of time on what I call EBM torture for you, but as we're interpreting these tests, just remember sensitivity and specificity are nice properties of a test that we look at, but these are defined on patients who either have the disease or don't. And the real issue that we look at in most cases is predictive values. And just to remind you of not all positives are true positives, and not all negatives are true negatives. And this is what disease prevalence at 10% disease prevalence, which I would tell you probably at no point have we had 10% prevalence of infection in our country. 90% sensitivity and 90% specificity means that all positive tests are about a 50% positive predictive value. I think for our PCR tests, it's actually probably better than that because they have they may have higher sensitivity rates at points, but just keep these principles in mind when you're interpreting tests, especially the rapid antigen tests in well people. The actual numbers of positives may be lower. On the other hand, we know that the sensitivities haven't been great, at least early on, and at certain points in the disease. So we have to be careful about the certainty we attach to our diagnostic test. I don't want to tell you that they're not accurate at all, because they do work very well. But just remember, when the test results don't match the patient in front of you at times, to keep that in mind. Skip over this right now. So of our available tests, again, PCR certainly are better, probably in both sensitivity and specificity than the antigen tests. Remember that serologic tests, certainly in the first 2 weeks, may not be sensitive. You're not making it enough to detect yet. Then as time goes on from acute infection, we know that antibody titers fall. And so several weeks to several months out, you could have been positive before, but then are negative at that point in time. And remember, some of our serologic tests actually will detect spike protein antibodies, which can be positive in patients who've been vaccinated, but other serologic tests detect other protein or detect antibodies against other protein antigens of the virus and not the spike protein. And so those are useful maybe for detecting natural infection as opposed to antibodies that might have been induced by vaccine. So we have ways to distinguish between those if that's needed. And just in terms of how we test, certainly nasopharyngeal specimens seem to be the most valid or provide the most accuracy. Looking at mid-turbinate specimens, which is a nice thing to do in children who you may not be able to have hold still long enough to actually get a nasopharyngeal specimen, those are good, but they're not great. And so again, keeping in mind maybe how the testing was done, what type of specimen was obtained, that's also a factor in interpreting diagnostic tests. A couple of things we've learned, again, in the pediatrics arena, we do know that maternal antibodies for COVID do cross the placenta, just like other IgG antibodies do. And the further you are along in gestation and the further the time from maternal infection to the point of birth, the greater the concentration of those IgG antibodies may be. And this may provide a degree of passive protection in neonates and perhaps a bit beyond. In terms of adolescent vaccination, we've been vaccinating down to 12 years of age. The one variable in these studies, a far smaller number of adolescents were studied than the adults 16 and up studies, where you had 20 to 40,000 people studied in those trials. So we had a lower number of children tested in terms of looking at safety profiles, certainly great efficacy in production of neutralizing titers. And again, 7 days after second dose, efficacy appeared to be 100% in the trial. Confidence interval could be a bit lower, but again, a really solid efficacy data. Of course, the thing that, and Dr. Sizemore alluded to this, has been the concern about myocarditis. That risk is certainly less in below age 30 and maybe higher below age 18. If you look at the data, a CDC study looking at identifying 484 cases in people less than 30 years of age from May through early June. Of those, basically 92% occurred within 7 days of vaccination. 304 required hospitalization, but there were generally mild courses and there were no deaths amongst those. Now, the numbers that come out of this are 40.6 cases of myocarditis per million second doses of vaccine. That again varies by age. If you look at males 12 to 17, that's 62.5 million per second doses, or basically 1 in 16,000 second doses. So not common, but not incredibly rare. The risk amongst females 12 to 17 is 4.2 per million. So far, far less, over a tenfold less magnitude of risk. So this is a greater risk in young males than in other age groups. Now, that's the risk of the vaccination for myocarditis. And again, it appears to be transient. We don't know the long-term outcome of that over 20, 30 years, but we know that it's at least acutely, generally significant. There's generally a rapid recovery. Now, what about the benefits? Well, vaccinating everyone in that age group per million second doses, you would prevent 11,000 cases, 138 ICU admissions, and 6 deaths. So when you do the math of that, the risk-benefit ratio is in favor of the vaccine, certainly when the virus is actively circulating like it is right now, and the risk of infection is there. But that's not to say that we have to be careful and communicate accurately and truthfully about risks, but put it in the context of the benefit as well. And many of the people who would have a myocarditis type reaction from the vaccine would certainly have a higher risk of such reactions or worse from the natural infection. This leads to, again, the whole discussion that's going on about mandatory vaccines. Obviously, there's a lot of opposition in the country right now to this. There's been growing opposition to this for other vaccines, our long-established vaccine programs in children. And we're trying to hold the line on a lot of at least maintaining those programs. Some healthcare systems have begun mandating vaccines. I don't see this happening, certainly for children or adolescents anytime soon. There is discussion about that. I think this will be an ongoing national debate for a while. Certainly, the earlier we are in a course like this, where there's more uncertainty and less long-term experience, I think it gets a little harder to push mandatory vaccines. But we certainly want to encourage things and communicate accurately and sympathetically to our populations. A couple of things, if you've had COVID and you get a vaccine dose, interestingly, natural infection plus 1 dose of an mRNA vaccine actually gives you better antibody response than 2 doses of vaccine without prior infection. And similar to this, as Dr. Sizemore alluded, looking at mixing and matching vaccines. 1 dose of the AstraZeneca adenovirus platform vector vaccine, followed by a dose of the Moderna mRNA vaccine, gives you higher titers and perhaps better or more durable antibody responses against other variants than the initial strain on which the vaccine was based. So we'll know more about this in time. I'm not, it's going to be a while before we're doing these approaches, but certainly there seems to be a possibility for benefit of this in the future. Now, in terms of children and spread, for most of the viral seasonal viruses that we have, especially influenza, we've known for 100 years or more that children, and certainly children in school, are a key magnifier of the annual seasonal epidemics that occur. So children become once a parent traveling brings a virus home to the child gets it from the parent, takes it to school, spreads in the school, goes back out in the community. that has been a dominant means of transmission within our communities for many things. But surprisingly, not so much for the SARS-2 coronavirus or COVID-19 virus. Children have seemed less likely to get sick, maybe a bit less susceptible, which doesn't mean they don't get it and doesn't mean they don't transmit it, but they don't seem to transmit it as effectively. And some early household transmission studies really seem to show very limited transmission from children to their parents, with the predominant means being the other direction. And early on, a lot of us were concerned that those studies were flawed, but they've turned out actually to have been pretty spot on. And it may be that children have fewer ACE2 receptors, although we also know they can actually carry higher virus loads. So it may relate to the volumes of air that they're exhaling and the distances which they are exhaling and the force with which they're exhaling because they're smaller. So it may be factors like that more than the volume of virus that's there. Again, several studies I'll show you. This was a cross-sectional study in Germany showing that during lockdown, the virus was not very prevalent in children, and they didn't seem to have boosted the pandemic in Germany. There have been similar studies again out of China and Switzerland. What do we know about schools? The couple of studies in New York City as well as in North Carolina. Again, with social distancing and mask wearing in schools, very limited impact on incidents. There was not an increase in community incident by children being back in school in person, again, with those mitigation efforts happening within the schools. Day camps, 54 YMCA camps. And again, these were not children crowded together. They observed small cohorts. They had a lot of hand hygiene, screening for symptoms, lots of training and cleaning of facilities, but saw very little cases occur. They had 9 youth staff, 9 youth and 8 staff had primary infections, but only 2 secondary cases amongst over 3,000 contacts in those various camps, again, with these mitigation measures. So seeing all of this together suggests that we can have children together and with relative safety in terms of spread of infection, again, with masking and mitigation, other mitigation efforts. Again, other school systems, again, with mitigation efforts, Salt Lake City and in Florida, again, across all ages. And we know in Hamilton County, we had a lot of in-person school last year, much more than in many places. And we did not see an impact of the school system being in session on the community rates. And we had very few cases amongst children in school, a bit higher in teenagers than in elementary and middle. The other thing that we've seen in this pandemic related to children is the multi-system inflammatory syndrome in children. We've seen something like this for years called Kawasaki disease, but they seem to be different. Things that seem to be more Kawasaki-like, a bit more rash and mucocutaneous in Kawasaki, and certainly higher platelet counts, whereas with the COVID and certainly MIS-C, tending to see thrombocytopenia, but significant overlap between these, but similar treatments. And if you look at this triangle, the other distinction is how do you tell MIS-C from actually acute COVID? And again, with the overlap, the multi-system inflammatory syndrome seems to have more cardiac involvement, a bit more mucocutaneous findings, more or less underlying conditions, interestingly. And you can see that happen after mild cases, higher neutrophil to lymphocyte ratios, lower platelet counts, and very high C-reactive protein levels in the blood. Again, a lot of overlap with Kawasaki disease. In both cases, you can see coronary artery dilatation. And interestingly, the treatment, the Kawasaki treatments have been applied to this with similarly good outcomes. A few weeks back, about a month ago now, New England Journal published 2 different studies of treating this multi-system inflammatory syndrome. One found no evidence that treating with IVIG alone versus IVIG plus steroids, glucocorticoids, or glucocorticoids alone In other words, all three approaches seem to work equally and generally with good outcomes. But another study, similar, slightly different methodology, IVIG plus steroids seemed better than IVIG alone. And a few months back, there was another study of children that, again, the combination seemed to work better as well. So we still don't know, but treating with any of those modalities, we seem to have good outcomes in these children overall. Neurologic involvement in children, again, with either acute COVID or multisystem inflammatory syndrome does occur as it does in adults. But again, these seem to resolve hopefully without long-term effects, although we're also all looking at long haul COVID, and we're going to have a lot to learn about that over time. Other issues in children, again, last year, masks were very effective. There's been some hope we could be back in school without that. The CDC, of course, has recommendations currently that may be a local decision, may not be mandatory. And one of the sections, American Academy of Pediatrics, has just come out recommending universal masking back in schools. So, of course, there's going to be ongoing debate about that. I think children generally have tolerated these masks very well, although there's a recent study out that apparently was produced by some folks who have an anti-mask bias, suggesting kids might not do as well in masks, but we have a lot of practical experience in other studies that say that it's really not a problem and there's not an issue with carbon dioxide retention. But again, as many things have become a bit politicized and debated, people hang on to the evidence that supports their views as opposed to trying to weigh it all together. We hope to have vaccines approved for children under 12 in the not too distant future, probably 2 or 3 more months. But that's going to be another debate on administering vaccination. What are the risk profiles or side effects going to be, and what is the risk of acute COVID in children, and what is the contribution of acute COVID infection in children to spread in other populations. So it may be a fairly hard sell, and I think we've got to work on the messaging on that very carefully. And then, of course, we're all watching the Delta variant, and there's some question, is that more infectious to children? It may be, but we don't know that for sure yet. We don't know if they're going to spread it more readily. So there are lots of things that we're still learning. And I think my favorite statement in the past year and a half has been, we'll know more in 2 weeks. And that applies every day to the next 2 weeks. We may have more insight than we do today. And we have to continue to watch for additional variants. And just to leave you with a thought about this, just know that, once this virus got into human populations, we were not going to have life as usual. If we shut everything down to avoid as much viral impacts as possible, we've seen socioeconomic and mental health impacts of that. If we are wide open, we have potentially more impacts due to the virus itself. So the goal is finding the lowest part of the graph here. But it's not zero. We can't get the suffering and death for this down to zero, but we have to work at it and work together and realize that what looks right today may appear to, in 2 or 3 months, to have been overkill or underkill. And so this is an ongoing process, and we have to work at this together. Lastly, during the pandemic year, last year, pediatric hospital admissions nationally plummeted, because the measures we took to mitigate COVID, we did not have a flu season. We did not have an RSV season. We didn't have a lot of other viruses circulating, which account for a lot of pediatric hospitalizations, especially October through March. But we're seeing rebound, and we are having an RSV season now in the Southeast. We've certainly had it here. It hasn't been nationally, but we've seen that, and we see other viruses coming back, and we believe they've not gone extinct. When school is back in session, and if we're not in masks in schools, we'll start to see these filter back in. And we do wonder if we might have a bit of a surge of some of these others, because we've got children who missed an entire year of viral exposures and have missed an entire year of thus immunity to those viruses. I don't think we'd see a double impact, but certainly something on the order of 1.2 to 1.4 times normal. So we are actually discussing how we might prepare for a small surge of pediatric admissions beyond our bed capacities here and probably even nationally. So we'll stay tuned for that. And with that, that's the last thing I have. We can stop for a bit of Q&A. Hopefully I answered all of your questions, and maybe we don't have any answers to any questions.
I've got one. This is Dr. Cooper. I'm curious, are there any validated post-COVID long hauler protocols to improve things? I see all these things, and it's hard to know the legitimacy. Some of them contain drugs like ivermectin, which Dr. Sizemore already pointed out in the comments in the chat that really hadn't been proven. So I was curious, is there anything legit out there that we can use seeing people in the clinic who come out of the hospital post-COVID long hauler?
Hey, good morning, Steve. I don't think, I don't think there's a lot of data-driven stuff yet to fully support any kind of unified strategy in dealing with this. I think anecdotally, there are some reports that patients who have long haul symptoms actually improve with vaccination. Again, mechanism behind that, it's not crystal clear to me, but there's some at least early reports that I've heard about with respect to that.
Thank you.
Yeah, and we'll be looking at this in children, but we're a long way from answers on that right now.
This is Brandon Morkowitz, cardiology. Just kind of a specific question, but regarding the myocarditis after vaccines, I think the benefit outweighs the risk in general, but for a lot of our kids with existing heart disease, we've kind of struggled with a specific recommendation for if it's good to get the vaccine or not. And just curious about your thoughts with kids with already underlying heart disease.
That's a great question. And, I think you have to, for me, it would come down to sitting down and looking at what's the risk of infection in the child. Can everyone around the child be vaccinated? And talking with the family, there might be some risk from the vaccine, but if there is risk that they're going to get the actual infection from some exposure, and that, we can't say with 100% certainty that if you would have this reaction with the vaccine, that means you would have it if you got infected. But there's a good chance that something like that's true, or there'd be a high correlation between your risk from natural infection and any of these sort of almost autoimmune type side effects from the vaccine. I wouldn't expect it to be 100%, but it'd be up there. So, right now with the Delta variant going and kids going back to school, it might favor vaccination. But if the parents felt like they would do a hybrid option for the child or online school for a while and watch, there would be other approaches for those families that might be reasonable. So I think it's a very much individualized risk-benefit ratio that, again, very individualized, which of course takes time and discussion and talking through with the family and depending on the age of the child and getting their input as well. And they're thinking on it again, along with their parents. So again, I think that's a complex decision and I'm glad to talk further offline about that or help figure out how to think about it with families. If we are able to shut this down, then it may, and viral circulation goes way down, then you could reach a point where you say let's watch this and not vaccinate that child possibly. Could be a reasonable decision.
So there was a good question in the chat about outpatient treatment of COVID-19. And again, outside of the monoclonal antibodies in those at high risk, there's not really any firm guidelines for to support evidence-based treatment of outpatients. The one exception would be if for some reason someone has an oxygen requirement related to COVID-19, would normally be hospitalized, but for some reason couldn't be hospitalized. There is some permissive language in the guidelines regarding outpatient steroid use in that setting.
And it was a year and a half ago, there was some discussion about an oral antiviral that would work similar to remdesivir, but I haven't seen anything or heard anything on that in months, which makes me wonder that it may not have panned out very well. Maybe someday.
All right, if there are no further questions, we can come to a close. Pam, are you good with that?
Hey, Jay, sorry, this is James Haynes. Just one quick question. Is there any thought of disseminating the vaccine to all the primary care clinics just to have easier access to give it rather than referring into a central spot? Or is it too hard of logistics?
I'll hop in real quickly on that. We have a monthly Zoom with our primary pediatrics community and the health department. Dr. Ego was on with us a few weeks back, and the health department's willing to supply vaccine to practices. So that's certainly a possibility. So any practices that are willing, I think the health department, at least for now, is potentially able and willing to supply vaccines with some regularity.
Great. Thanks a lot, Dr. Wood.
Yeah, hey, Jim,
Hey, good morning, Dr. Wood. This is Dr. Urego from the health department. If anybody's interested, all they need to do is sign up with the state to become a vaccine provider. There's some paperwork, but once approved, we are happy to provide as many vials, 1 vial or 100 vials, or whatever that practice may want. So just let me know, and I can certainly help with that.
Great, thanks.
Jim, I would say the other logistical challenge that we face, just as we've tried to bring vaccine into SEMPA, is just, just the logistics of waste and trying to minimize waste and weigh the kind of, or balance out the benefits of what if you're going to open up a vial of 10 doses and you only have 2 people to vaccinate, and then eight go to waste. And so it's trying to figure out what that balance is, or trying to, get your schedule in a way where you can get as close to 10 people there, so you can try to minimize the waste. At least those are some of the challenges that we've faced at our place.
Thanks to all of you very much.
All right, we'll let you all get back to work.
Thank you to both of our speakers this morning and for everyone who participated. Kim will share the link later this afternoon once we get the recording uploaded. Okay? Again, thank you both.